Okay. Motion? I think we'll kick off.
Okay. So thanks everyone for making the meeting. My name is Mershan Pillay, and I am currently the chair of the IALP Dysphagia Committee, and very, very pleased to welcome Jo Murray, Sebastian Dolken, and Suleika Gunasekharan to our first webinar for 2025. I'm really pleased you accepted the invitation to be part of this, and I cannot wait to hear what you have to say about the topic. It's of particular interest to me, so I'm really grateful for you doing this. I'm going to hand over to Michelle just to introduce you a little bit more, and good luck and enjoy this in the webinar. Thank you.
Thank you, Mershan. I'm joining you from the lands of the Wurundjeri Woiwurrung. I pay my respects to their elders, past, present, and emerging. Just before I introduce our speakers, I'll just do some quick housekeeping. If you have any questions during the presentation, please type them into the chat in your Zoom control panel, and we'll aim to address these questions with our presenters at the end of the presentation. So, as Mershan said, we're absolutely delighted to welcome our presenters today to kick off our very first webinar. And thank you to all of you for joining across the world. It really is a global event, this webinar, and we're really excited to have our three speakers kick this off. I'll introduce all three speakers, and then I'll be handing over to our speakers. So Ms. Suleika Gunasekharan, Suleika is a speech pathologist and a PhD student at Flinders University. Her research in clinical reasoning and decision-making during clinical swallowing examinations earned her first-class honours and a journal publication. Suleika is interested in enhancing clinical reasoning of speech pathologists to ensure high-quality clinical care and positive patient outcomes. Professor Sebastian Dolken. Professor Dolken is a former NHMRC postdoctoral research fellow. He leads the Swallowing Neurorehabilitation Research Laboratory at Flinders University. With over 80 publications, he's internationally recognised for his research on functional swallowing assessment and clinical reasoning. He also develops novel clinical courses in the College of Nursing and Health Sciences. Dr. Joanne Murray. Dr. Murray is a senior lecturer at Flinders University. She has 25 years of clinical experience in, I'm sorry, I haven't progressed my slides. I'm sorry, everyone. Jo teaches acquired language and cognitive disorders and research methods. She is recognised internationally for her research in post-stroke dysphagia, free water protocols, oral healthcare, hydration, and clinical reasoning. So welcome, and I'm just going to now hand over the controls.
I'm just going to share my screen. Do you see the screen? Is it sharing?
I do. Thank you.
Yep. Alrighty. Thank you so much, Michelle and Mershan, for the lovely introduction. Hi, everyone, and welcome to today's webinar. Before I begin, I'd just like to thank the IALP team for organizing this webinar and inviting us to present our work in clinical reasoning. Thank you all as well for joining us from all around the world, hopefully not too early from wherever you're joining from, but we're really looking forward in sharing our work with you around this very important and interesting topic. I'd also like to take this opportunity to acknowledge the traditional custodians of the land of which my team and I are presenting from today, so the Kaurna people, and pay our respects to their elders past, present, and emerging. So as we're talking about reasoning and decision making, have you ever wondered how we make decisions in our day-to-day life? For example, how did you decide to take that umbrella out with you today? Did you know it was going to rain because you read the weather forecast? Or did you pick up the clues that it was dark and gloomy outside? Or maybe it's winter and it's been raining for 5 days straight, so you automatically assume that it's probably going to rain today, so let's just bring the umbrella just in case. So reasoning and decision making is such an important part of what we do in our day-to-day lives as human beings, but especially important for what we do as clinicians, researchers, and academics, who I'm assuming are most of us who are here today. So as clinicians, we are driven by having greater understanding of swallowing pathology to conduct better assessments, utilize predictive models, and create specific patient-centered interventions. From an academic perspective, we want to instill better understanding of swallowing physiology and biomechanics in our students, and support them to have better understanding of assessments, predictive models, and the different interventions out there. So from both sides, our common goal is to enable best possible patient care. And one of the mechanisms on how we can achieve this appears to be solid clinical reasoning. And that's what drove our interest into evaluating clinical reasoning, because it helps improve practice and it also helps improve education to then improve practice. Therefore, to help us gain solid understanding of how to improve practice, we first had to understand how is clinical reasoning enacted in practice. And this is what we hope to unpack in today's presentation. So I'll just run over the content of today's webinar. Firstly, we have Professor Sebastian Tilken, who will be talking to us about the development of clinical reasoning. And then I will take over to discuss how clinical reasoning informs decision-making during clinical swallowing examinations and how it evolves across acute admission. And then we'll have Dr. Joanne Murray, who will be facilitating a dysphagia case study. Then we'll have some time for questions at the end before we wrap it up. And now I will pass it over to Sebastian.
Thank you, Sue, and thank you everyone for making the time to join us today. It's a great pleasure to be able to speak on this topic. When we first started exploring clinical reasoning, looking at it from both a clinical and a clinical education point of view, we scanned the literature around what is available in the speech pathology context, and then also specifically in the dysphagia assessment and dysphagia management context. And while there were a few studies here and there that touched on clinical reasoning in these spaces, there wasn't really a big body of evidence. And so we looked a bit further afield to see what information we can borrow from other areas of clinical practice. We came across the dual processing theory in the area of cognitive psychology, and we borrowed that lens and applied that on our research going forward. Now, Sulika will explain a bit more about this body of work going forward. And so I thought we present a little bit on the background of the dual processing theory as a foundation to the work that Sue will be presenting on. The dual processing theory essentially talks about how we as humans make decisions and what sort of thinking styles we engage in to reach decisions. This can be in the clinical context. There are lots of other different contexts as well. And it essentially talks about a continuum of ways of thinking. On the one side of the continuum, sort of referred to as system 1 or type 1 reasoning. That's more of an intuitive pattern recognition based kind of thinking. You might refer that as your gut feeling kind of thinking. It's where we have a hypothesis or a view very quickly, sometimes within milliseconds, based on a pattern that we're observing in a situation around us or in data that's available to us. That sort of reasoning, like I said, is very gut-based, very intuitive, and lends itself quite well to hypothesis generation or inductive kind of thinking. So we observe a pattern and we think a certain scenario might be the case. On the other end of the continuum is the so-called system 2 or type 2 kind of reasoning. We employ that kind of reasoning a bit more when we don't see a pattern in the environment or in the data that we're looking at straight away. And this system 2 type reasoning allows us to collect information and collect data to then start creating patterns. And this system 2 is a very analytical, processed and rules-based approach to thinking. It relies on step-by-step data or fact gathering, and is therefore slower and perhaps more effortful, but also at the same time more thorough and more data-driven. This type of approach lends itself really well to deductive hypothesis testing. So you can see that the two ends of the continuum really work together quite well, because the one end helps us generate hypotheses, and the other end, the other way of thinking, allows us to test hypotheses. Now, to put a everyday kind of example to this, I'm trying to progress Sue's screen here, which doesn't seem to be working. Sue, I might get you to progress from your side.
Yep, that's okay.
So if you throw in an everyday kind of example, and my students tell me don't have mathematical formulas in your presentations, but I just snuck in a very little one to illustrate what I mean. So system 1 is, if I asked you what is 3 times 3, then very easily you would process this information as a single unit of information, which would then lead you to think, well, the answer is 9, because you have seen this information before, and you recognize 3 times 3 as a single unit of pattern that you would process in one thing. Now, if at the same time I asked you what is 27 times 3, so I think we might go with a hand signal going forward. So 27 times 3, then you would have to process that, because we're not so familiar with that formula, in individual units. So we apply the system 2 kind of thinking of mathematical step-by-step processing. So some of us might say, well, it's 20 times 3, that's 60, plus 7 times 3, that's 21. So together we get to 81 as an answer. Others might say, well, that's maybe something like 30 times 3, that's 90, minus 3 times 3, that's 9, 90 minus 90 minus 9 equals 81. So different ways of collating the information, but we still get to the same answer. Now, if I said to you, 27 times 3 is 1,578, you would immediately know, though, that that can't be the right answer. And that is because even though we're doing step-by-step processing, we're also at the same time processing the information as a unit, as a way of gauging a relatively most likely kind of scenario, even in the step 2 kind of type 2 kind of reasoning. And so we might know it's somewhere around 100. We might not know it's exactly 81 until we've done the step-by-step processing, but we certainly know that it's not 1,578. And so even though there are 2 different ends to this continuum, we do engage in this in an overlapping kind of fashion. So it's a balancing act. And system 1, as the more gut-based pattern recognition kind of way, would lend itself to inductive reasoning, or something like, this information, this pattern makes me think that. Whereas on the other end, we've got more of deductive reasoning in the form of, this information confirms or refutes a hypothesis that I've previously formulated. And keep those 2 inductive, deductive reasoning processes in mind, because this is what we'll talk about more when we talk about the research studies. Now, we came to this scenario in the context of clinical education. So you might have come across this as well, either in yourself or in your students or early career colleagues, where the information that we teach in the classroom seems to be pretty clear across all levels of academic performance. But when we move towards clinical implementation of that information, sometimes there's a bit of a barrier where basic information, foundational information, doesn't translate into clinical practice very easily. And so we were interested in understanding how we can teach clinical reasoning better, and even how clinical reasoning actually works in the context of dysphagia assessment. And of course, we acknowledge that this is a really complex process, in that we have to collate information from different sources into a cohesive picture. And that is cognitively really demanding. And we also know that it becomes easier with increasing clinical expertise. So our next question was, well, how do we develop clinical expertise then from being a novice to being an expert? And again, we had a look in the literature outside of the speech pathology context, and we found two quite interesting views. First view is around the sort of traditional view, and traditional not meaning outdated, but perhaps superseded by additional ideas or additional views. The traditional view being that expertise simply develops because we accumulate more knowledge. In other words, experts know more than what novices do. The more contemporary view is that expertise develops by a restructuring of the knowledge that we have. So it's not necessarily about how much someone knows, but how that information that they do have and do hold, how they use that in clinical practice. And it seems like these processes of using information are far more important than the amount of information that someone holds in terms of determining whether they're an expert or a novice. So how do we then restructure knowledge if that is what makes the difference? And there seem to be different phases along that continuum or along that process. Phase one, or an early phase in this process, and that is the same for every novice and everything that we do in our lives, so it's not limited to clinical practice, is that we first need to accumulate bits of information or bits of knowledge. So in the speech pathology, dysphagia management context, that might be things like understanding swallowing biomechanics, understanding neurophysiology, which assessments we have and how we use them, what they tell us, what interventions we have, and so on. So they're explicit units of knowledge. So if you will, it's a bit like, and this is where I come from a family point of view, when you have kids with Lego around the house lying everywhere, they're a bit like Lego pieces. And we've got a box of Lego pieces relating to cranial nerves, around clinical symptoms, anatomy, physiology, assessments, interventions, and so on, lots of different colors. And it's a bit like our students taking their hands full of knowledge or Lego pieces into clinical practice. And it's now about teaching them how to combine those Lego bricks in the process of clinical reasoning. So step one is about accumulating as many Lego pieces as we can. Step two then is about identifying patterns in this knowledge or in the Lego pieces that we're talking about. And the education, the medical education literature refers to this as the process of encapsulation. In other words, we're building chunks of facts that seem to be related to certain clinical presentations or clinical cases. And the more we are exposed to that, the more refined these patterns become. So for example, if I said to you, think about a case that presents with sudden onset of the impairment, unilateral impairment, and aphasia, then probably in most of your minds, you'll think of something that's related to stroke, because it is typically unilateral, it is typically sudden onset, and it can quite often be associated with aphasia. So if we take this back to the Lego example, then we place certain Lego bricks into a pattern or a chunk, like sudden onset, like unilateral paralysis, like cranial nerves, unilateral facial drooping, and so on. So this becomes our first pattern. Now, similarly, we might recognize a different set of Lego bricks, like long-term decline, like progressive dysphagia, like levodopa responsive, into a different pattern. And I'm sure you'd agree that if you hear those things and throw tremor into that as well, then you would package this up as perhaps a Parkinson's disease pattern. So distinct bits of information that are patterned into common groups that we would see in clinical practice. Now, step three takes this process a bit further, and really step three is what we iteratively do across our entire career. Because as we identify these chunks or these patterns in step 2, we then link patient contextual information into those patterns, into those encapsulations. So things like risk factors or their personal stories or medications that they were on, environmental factors, their preferences, their lifestyle risk factors, and so on. So individual case informations that gets added to those chunks, which we now then call illness scripts. And they help us refine our identified chunks that we put together in step 2. So for example, if I said sudden onset, unilateral impairment, 85-year-old male, high blood pressure, found unconscious in the nursing home, again, you might think could be stroke. If I had to pick one, probably would pick stroke. But also if I said to you sudden onset, unilateral impairment, 25-year-old male, surfer and mountain biker, found unconscious in front of the pub, then the contextual information might steer you in a different direction, and stroke might not be the first kind of hypothesis that you come up with. So these contextual informations are quite important in refining our chunks. So last time, if we bring this to the illness scripts in the Lego example, then if we're adding all of our contextual information to this, the stroke pattern now becomes the stroke illness script. And the more we see of that, the more refined or the more expert we become in identifying these illness scripts. So how do we use this restructured knowledge? Well, as clinicians and as expert clinicians, we identify these patterns and they help us determine hypotheses based on these patterns. And then we test these hypotheses during our assessment. So this process is both efficient in that we hone in on a likely scenario based on our experience, type 1, but also then testing our hypothesis, being accurate, being step by step, using type 2 kind of thinking. Novice clinicians, on the other side, don't quite yet have these well-defined illness scripts, mainly on the reason that they haven't seen as many patient examples just yet. So they rely more heavily on the biomechanical, pathophysiological step 1 kind of data. So there are lots of Lego pieces that still need to be identified into a pattern kind of process. So in other words, the two, system 1 and system 2, kind of sit side by side, and on this continuum between novice and expert, they kind of overlap with each other. But they're not a tug of war. So system 1 and system 2, inductive and deductive reasoning, they work together as this finely tuned interaction, and each can kind of control for and make up for the shortfalls of the other. So, for example, when an expert comes across a scenario or a pattern that they seem to be familiar with, but they suddenly see a very unusual clinical presentation, then they might revert back to a system 2 approach where they now systematically test everything just to make sure that they're not missing anything that they haven't come across before. So in other words, experts are experts because their reasoning primarily relies on really good and effective and refined illness scripts. So then our question was, well, how do we get students to develop those illness scripts so that the step from the foundational curriculum right on the left of this image to the box in the middle, like the novice real-world experience that they might have on clinical placement or internships, or really the early professional years, that this step isn't as big as it would appear, and perhaps make placement transition a bit easier. And one of the things that sort of has come from what we've found in the literature around us was that there's kind of two things that we can all contribute. One is that experts like clinical educators on placement could help the process by unpacking their own clinical reasoning and being aware of their own clinical reasoning to help students understand how their clinical Lego pieces are put together. And at the university side, we can teach foundations in clinical case contexts so that the bits of Lego that we teach about stroke and neurodegenerative disease and so on are immediately attached to clinical cases or case examples, so that this information becomes part of emerging illness scripts for our students. And we think that those two approaches might make that transition a lot smoother into clinical practice. And so the end point to all of this was that we really wanted to understand what experts actually do during initial swallowing examinations. And that was one of the first studies that we did in this body of research. Stulika will walk you through some of the methodology in a minute because she used the same approach. But let me just add to this that there were two key findings. The first key findings was that there, perhaps not surprisingly, 4 really well-defined phases of data collection and assessment in the way we come up with management recommendations as experts in swallowing examination. One is pre-bedside data gathering, then a patient interview or a conversation, then a direct assessment like cranial nerves or motor exam, swallowing trials and so on. And that then led to management recommendations. And that was quite consistent across all the examinations that we had a look at. And the second key finding was that expert clinicians engage in exactly this dual processing theory cycle. Inductive hypothesis generation, followed by deductive hypothesis testing, and an iteratively cycle between those two systems, sometimes 30, 40, 50 times per assessment to land on a management recommendation from there. So this is just a bit of a background to the theory behind what's underpinning this research program. And I'll now hand over to Sue to talk us through the study that she led. That was the most recent study in this piece of work.
Thank you so much, Seb. So from all this work that Sue McAllister and her team did, there were a couple of questions that needed further answering. So specifically, there were what further information was gathered over time after the initial recommendations were being made, how the new information gathered influenced the clinician's reasoning process, and also it was quite unclear whether the inductive, deductive reasoning cycles influenced the patient's outcomes in any way. So I came along as an honor student a couple of years back and worked alongside Seb and Joe to conduct a longitudinal study evaluating the reasoning processes undertaken by speech pathologists over a full episode of patient care. So that's from referral up to discharge from speech pathology care, and how they inform decision making. So we also evaluated the accuracy of decision making against longer term outcome data. So we used a similar study design to the expert study conducted by McAllister and her team and adapted it to fit the longitudinal study approach that we were having. Our study was conducted in a metropolitan acute care hospital in Australia, where we recruited 2 speech pathologists. So once we got their consent, they were told to contact us if they had any new referrals for an initial swallowing examination. So from there, we managed to recruit 6 patients of different presentations, which led us to having 6 speech pathologist patient dyads. So when the speech pathologist would contact me with a suitable patient, I hurried to whichever ward the patient was at with my camera and tripod stand. And after introducing the project to the patient and getting their verbal and written consent, I would set up the camera at the corner of the room to record the clinician's initial swallowing examination. Then I would wait outside to avoid any bias for when I interview the speech pathologist later. So after the clinician has completed the assessment, I then interviewed the clinician individually using a retrospective, semi-structured think aloud method, which has been widely used all around the world looking at clinical reasoning. So during the interview, I prompted the speech pathologist to unpack their thought process using the video recording to support their recall of what happened during the assessment. I then did follow-up interviews with the clinician whenever they had any direct or indirect contact with the patient after the initial assessment and all the way up to discharge. So things like file checks, video fluoroscopic swallow studies, reviews, multidisciplinary meetings, discharge planning, and so on and so forth. So those occasions were not video recorded, and our interviews focused on any new patient information and how it was integrated into their reasoning and decision-making process. So we also reviewed the patient's files following their discharge from hospital for any adverse respiratory or swallowing related outcomes that were reported during their admission. So we were looking out for things like aspiration pneumonia, chest infections, choking, any changes to their dysphagia management plan, or even if they required a re-referral to speech pathology. So all interviews were mapped word for word into a descriptive concept map to provide a visual representation of the interview and the clinician's thought process. Here we have an example of a descriptive map. As you can see, there's a lot going on in here, and I'm not expecting for any of you to be reading it all, but it just shows how complex our clinical reasoning process looks like. The box you see are referred to as notes, which hold facts and concepts, and the connecting lines between the rectangular boxes, the notes, we call as links to show relationships and cognitive links made by the clinicians. So the different colors we have shows the different instances the clinician had any direct or indirect contact with the patient. So to give you an example of how we coded this, we have here a small part of the transcribed interview where the clinician was describing her cranial nerve 12 assessment. So I'm just going to read the transcribed interview. So then I jumped across to cranial nerve 12 to have a look at his tongue. Very minimal protrusion just through his lips, very slow movements, very reduced range of motion laterally. So his tongue, because it was quite weak and slow, I imagine that any oral preparation, any oral manipulation, or any anterior-posterior transfer was going to be very slow or incoordinated. So just like that, that's how we mapped up all the interviews for the 6 speech pathologist patient dyads. And as you can imagine, the descriptive map was huge and complex, so we had to take a step further to create a reasoning map, which only coded those facts that led the clinician to generate a hypothesis, or those facts that allowed the clinician to test the hypotheses. And this made it easier for us to look out for the different types of reasonings that were being used. So this is the reasoning map that corresponds to the previous descriptive map that we saw earlier. And then zooming in, so you can see the reasoning map maintained the structure of the clinical swallowing examination. And now bringing back the concepts of inductive and deductive reasoning that Seth was mentioning earlier. The green links represent the generation of hypotheses. So that's the inductive reasoning, while the red links represent the testing of the hypotheses. So if the clinician was confirming or refuting the hypotheses, and that's showing deductive reasoning. So with the same example from before, the clinician saw minimal tongue protrusion and slow reduced tongue range of motion, which led her to think. So she's hypothesized that there will be slow anterior-posterior transfer. So that's showing inductive reasoning. The next day, when they went to see the patient to do an oral trial, she saw very slow anterior-posterior transfer, which then confirms a hypothesis showing deductive reasoning. So just like that, that's how we went about identifying the types of reasonings that were used across all 6 maps. And finally, we created a hypothesis map to identify the types of hypotheses that were generated across the patient's admissions. So this is how our hypothesis map looks like. So this map corresponds with the previous maps as well. And now taking a closer look in this map, the hypothesis generated earlier regarding the slow anterior-posterior transfer was coded as a motor function type of hypothesis. So each type of hypotheses were coded in a specific color. So as we can see, all the motor function related hypotheses were coded in green. So then this map allowed us to identify the common types of hypotheses that were being made in all 6 maps. So all 3 maps gave us lots and lots of data. And based on all of that, we started to see a pattern that was consistent with the McAllister paper, whereby during the initial swallowing examination, speech pathologists presented with the same structure of how they would conduct the assessments. So the clinicians will receive a referral, collect some data during their pre-bedside assessment. So for example, looking through patient files or talking to the nurses or talking to the doctors. Then they start generating some hypotheses showing that inductive reasoning. Then they would go in to see the patient and do a bedside assessment, which then allowed them to collect further data and allowed them to test their hypotheses. So either confirming or refuting them. So that's showing that deductive reasoning. So these cycles of inductive deductive reasoning continues as they gather more information across their initial assessment until they were able to use their clinical judgment to then make a decision around their management plan. So similar to McAllister's study, we saw that the information gathered were tailored specifically to the patient. For example, facts that were analyzed using the inductive reasoning, so where they would come up with a hypothesis, this would lead the clinician to find further patient-specific information for them to deductively test the hypotheses. So the tailoring of information led them to formulate patient-centered management decisions. So when the speech pathologist follows up with the patient the next time, either directly or indirectly, we can see that the patterns of iterative cycles continues all the way up to discharge. But as you can tell, there were some differences seen in the amount of data collected and the frequency of reasoning types being used. So let's start off focusing on the inductive reasoning. So that's in the far left. So there are thicker inductive reasoning arrows, which represent a more dominant use of hypothesis generation. So the same was seen with the number of facts gathered at this and this basically means that initially there were lots of new patient information and there are lots of hypotheses that will be generated. As the patient progresses through admission up to discharge, these arrows representing the facts and inductive reasoning becomes progressively thinner, so indicating that there are fewer new facts that are being gathered, therefore less hypotheses that were being generated. So on the other hand, the deductive arrows were becoming more progressively wider and more dominant as the patient progresses towards discharge. This shows that the facts that are being gathered are mostly used to evaluate the hypotheses and decisions that are being made for the patient. So for example, you're going to see a patient for an initial assessment who's presenting with a more severe dysphagia. You've collected all this information of which you have generated some hypotheses for. So during your cycles of inductive deductive reasoning, you've used your clinical judgment to make some relevant decisions and management for the patient. At this point, you may have lots of hypotheses that probably needs answering to help you better determine your management plan. So you decide that you want to do an objective assessment. You need more objective information to ensure that your assessment of their swallowing physiology or biomechanics is correct. So the next day you complete a video fluoroscopic swallowing study. So the objective information you gather from the video fluoroscopic swallow study allows you to confirm the hypotheses you had from the day before. So you make a recommendation from there, and then you keep the patient for review to ensure that they are tolerating the recommendations for a longer period of time. So then you go in to see the patient the next day or the day after, a few days later, and you review the patient files, talk to the nurses, maybe going to see the patient for review at bedside, and all the information that you've gathered at this point shows you that the patient is tolerating and managing their recommendations. So this new data gives confirmation that your recommendation plan is safe and suitable for the patient. So from the example, you can see that the stronger influence of the inductive reasoning at the start and how it progresses towards a stronger use of deductive reasoning towards the end. The more dominant representation of deductive reasoning as patients progresses through admission allows us to make the most appropriate decisions or plans for our patients. So if something goes wrong or if there's any potential changes in the patient's status, for example, one of our participating patients had a change in their goals of care. So then the clinician will go back to review previously gathered information and gather more new information based on the current circumstances. So they review their hypotheses and decisions and make appropriate decisions to manage these unexpected changes. Again, here showing that they are still tailoring their decisions based on the patient's needs. Therefore, when we are making decisions and considering different management options, it's important to acknowledge that by using those inductive, deductive reasoning cycles, it gives you the opportunity to step forwards and backwards in your reasoning, and therefore allows you to refine and monitor your decisions that are being made. So we also hypothesize that as patients progress through their stay in hospital and using that inductive, deductive reasoning cycles, it is likely that there are less resources that are being used with each follow-up, as we've represented this in the size of the cycles becoming smaller and shorter with time. So it's indicating that there's less number of reviews needed, less assessments required, less physical resources that would be used, less cognitive load on the staff, less time spent, and overall less cost towards the healthcare system. So I also just wanted to bring everyone's attention to the QR code at the corners, which I've linked up to the clinical reasoning paper if you would like to read more about it. So our study also found that there were no adverse outcomes identified when the cycles of inductive, deductive reasoning was used. So this likely tells us that using both systems of reasoning allows us to balance the pros and the cons of one another. So we're benefiting from the quick assessment process by tailoring the data that's been gathered and generating hypotheses from these to gather more specific patient data. And then we are balancing against making a mistake or error by relying on our deductive reasoning to check and confirm our hypotheses, to check our reasonings, and to check our decisions. So this makes it an effective and efficient process of clinical reasoning, particularly when you're in an acute setting and everything's fast-paced and there's high patient intake, high patient turnover. And now I'll hand it over to Jo to discuss more about the types of data that we gather and how it influenced the decisions that we make.
Thanks, Sue. Hi, everybody. I'm going to continue, but Sue, I wondered whether if you just stop sharing your screen there and share it again, we might get rid of those annoying red lines that have popped up that really played with your deductive and inductive reasoning maps.
Right. Okay.
Can you see them? If you just stop sharing and then share again, we should be good. And while you're getting started on that, I'll just say hello to everybody. Well done. Thank you. So as Sue said, I'm going to take the model of clinical reasoning that Sue's just introduced to it and situate it into another framework called the Situated Clinical Decision-Making Model by Gillespie and Patterson. So I'm not sure if I've got control, Sue, or if you... No. Okay, let's see if this works. Sorry, that's not working for me either.
No, it's not. Okay.
No, so can you move that on, please?
Yeah, that's okay.
Technology, people. So this is the Situated Clinical Decision-Making Model by Gillespie and Patterson. And this really, we can see centered in the middle is our thinking, our reasoning. But this model helps us to think about where all the facts come from that will assist us with our clinical reasoning, and also what else influences our thinking. So first I'm going to take you through the model, and then I'm going to illustrate the use of the model in an authentic case study. So first of all, for example, we receive a referral from a patient, we get some background information, usually about their medical diagnosis, and this is all about knowing the case. Knowing a typical presentation for someone with that medical diagnosis and the course of that disease. And this really lines up nicely with what Seb was talking to us about illness scripts. As expert clinicians, we're already hypothesizing how this patient might present even before seeing them because we're using our type 1 intuitive reasoning. And then we collect some more data about the patient, their specific case history, their reason for admission, and then we conduct our own assessments, tests, investigations, look at what else has been done, and collect more information that feeds in to our hypothesis generation. Then there's knowing the person though, going and talking to the person and knowing what's really important for them, for their care, and that all contributes to our decision-making for patient-centred care. But we all work in a context. So part of that context that influences our clinical decision-making is knowing our profession. What are our standards of care? For example, we have a code of ethics usually. We have guidelines, for example, for stroke that might influence our practice. We might take advice from supervisors or mentors, and that too influences our practice. And added to that is considering our own biases and what we bring to the table in terms of our own experiences. How many years of experience do we have, but also what have we experienced? Have we actually experienced anything really adverse on the wards that really influences our personal view of risk, for example? And all of that happens in a context, be it an acute fast turnover ward, but with a medical team at hand, or if we're out in the community, perhaps on our own with our patient. And research evidence comes into that too. Thanks, Sue. So let's work through this model with a case example, Mary. And Mary is a real person, although I am using a pseudonym and a stock image. This case came from some other research that Seb and I did, looking at how clinicians make decisions about free water protocols and whether their patients in geriatric and stroke care are suitable for a free water protocol. So most of you will know that a free water protocol allows patients who we know to be aspirating thin fluids to drink water anyway, on the premise that it's pH neutral and will do no harm to the lungs, but obviously under certain circumstances. So how do you decide if a patient like Mary is suitable for a free water protocol? Well, let's look at the two models now of decision making side by side through this case of Mary. So Mary, we find out, is 89 years old. She has a husband who's her primary carer. She was admitted to a private hospital with a lower respiratory tract infection and transferred to our hospital to a general medical unit due to functional decline and suicidal ideation. She's quite functionally dependent and weighs only 43 kilos. So all of that information is telling us about this patient. And you can see that here on the situated clinical decision-making model. But put that together with her past medical history of, you can see there a fairly significant cardiac history, some mental health issues there as well. Put together with knowing her age, her weight, we're starting to form a picture here. We're starting to understand the case. And we've seen these before, people like this who come in with all of these kinds of symptoms at her age. And we're starting to think this is a fairly frail, both physically and psychologically, older woman. And we're starting to think she might be a bit vulnerable, and we're perhaps starting to be a bit more conservative with our thinking. So we decide we'll collect some more facts through our initial swallowing assessment. And we find that she does cough on thin fluids, Her cough is weak and she quickly fatigues. So they're not really positive signs towards a free water protocol, perhaps. But what we can see that is we're already starting to use that initial cycle of inductive reasoning, generating our hypotheses and starting to test them. And the speech pathologist who did that landed on a recommendation at the end of that first cycle of reasoning to recommend an ITSE level 5 minced moist diet, ITSE level 2 mildly thickened fluids. I'm getting through this pretty quickly in the interest of time. And just to see these iterative cycles of reasoning, we can see that, okay, a bit later on in her admission, the speech pathologist decided to conduct a video fluoro study and saw that she, yes, confirmed the hypothesis that she was penetrating on sips of thin liquid, but progressed to finding out that if we gave her the water with teaspoons, she wasn't penetrating at all. Other good signs were that her chest was clear, her vital signs were stable, but concerningly now, another piece of information's added to the mix that her fluid balance chart indicates she's only drinking 380 ml of water, of thickened fluids that we've been recommending on average per day over that 7-day period. So now we're starting to hypothesize that other things might be going on and that we need to test. We also want to acknowledge the person in all of this, knowing the person, because she says to you, oh, I really want a cup of tea or at least a drink of water just to buck me up a bit. And her husband really just wants his wife to be happy and comfortable. But as we discussed when we were looking at this framework, there are other things that influence our decision making. Knowing our profession, what would other members of our team do, especially our supervisors? We are very much influenced by mentors and norms of practice when they're weighing up a free water protocol. What about our own biases, knowing ourselves? What's our tolerance for risk? Sorry, they should have been coming up there. Thank you, Sue. You know, based on the years of experience, or perhaps my experience of being on a ward where someone choked, and my risk tolerance is very low. What about the support of the multidisciplinary team and having the setting being supportive of my decisions, or alternatively, being out on my own in the community and not having that backup? What does the research evidence say about free water protocols? Maybe it's changed since the last time I looked. That's a context that perhaps I need to consider. So you can see there's a lot going on when we're using our clinical reasoning to manage patients with dysphagia in a safe, efficient, and patient-centered way. And, you know, no wonder you're tired at the end of the day. Let's go to the next slide. So all of those things contribute. Sorry, yeah, thanks, Sue. So let's bring it all together now and consider what that means for practice and education. So what we can see through Sulika's model and our previous research and the second model that I introduced, as expert clinicians, we really do collect information from multiple sources, and there are many cycles, these iterative cycles of inductive and deductive reasoning that we go to really make our decisions for safe but efficient patient-centered care. And the good thing is that the two types of reasoning, creating a hypothesis and checking through fact collection, really makes it efficient without necessarily creating errors, which balances those negative flaws in each of the types of reasoning if we used only one alone. So what we'd really like you to take away from this is that efficient, safe, and person-centered practice can come from self-reflection. Where do where you really do think about your own thinking, what led you to one decision over another, checking on your own biases, making sure you haven't overlooked anything. And there are implications in this for teaching. We want to educate our next generation of speech pathologists, speech language therapists to be good at clinical reasoning as well, so that they can be efficient and safe and patient-centered in their care. So if we can explicitly show them and unpack for them how we think about our clinical decisions, how we make our thinking visible to them, will go a long way to helping them develop their own clinical reasoning. This is something we're really excited to be doing in our academic program through, as Seb said, lots of case-based discussions and simulations and putting their reasoning into practice. But we're also encouraging our clinical educators out in the field to do this with students on placement. So thank you for listening to my section, and I'll hand back to Sue for some final words.
Thank you, Jo, so much for that. I'm just going to find words. Yep. So this brings us to the end of our presentation. I'd just like to leave you with this quote from one of my clinical educators during my university placement, which really resonated with me and highlighted the significance of good clinical reasoning. So as speech pathologists, we are the experts in communication and solving problems. It is the why behind what we do that is critical for patient success. And I hope that we were able to unpack all of this for you in today's presentation. Thank you.
Thank you all so much. Thank you, Sue, Joe, and Seb. Your presentations were fantastic. You really did an excellent job of talking about some really complex concepts, and in a really enjoyable way, in ways that help us make sense of what's a really important aspect of our clinical practice. I personally really enjoyed your presentations, as I'm sure the audience have as well. We've got a few questions in the chat, if I can just work through those. And I think that the committee members may also have a couple of questions they may want to. I might invite Mershan or Noga to come in and ask some questions too. Laura, thanks for your question. I'm just going to read this out here. This reminds me of the clinical reasoning cycle by Tracy Levitt-Jones. Have you seen this model, and how do you feel this mirrors your own study about clinical reasoning in speech pathology?
I'm happy to briefly.
Yep, thanks.
Thanks. So yeah, happy to speak to that, Laura Jane. That's a really good question. I think what we see in that particular reasoning cycle is what's common across these different ways of kind of illustrating clinical reasoning is, I think the theme that comes through this is a cyclical kind of approach to reasoning. And so I think there's quite an overlap there between the way we're visualizing how reasoning works and how we're engaging in reasoning. It's about collecting information, making decisions, but not stopping there, but continuously evaluating what we're doing, either formally or informally. So it does not have, evaluation doesn't mean research, but monitoring the outcomes for our clients, therefore collecting more information and then re-evaluating that. So there are different ways of thinking about it, but they're all cyclical in nature. They're recurring phases of inductive and deductive reasoning. So I think there's overlaps in how that is depicted. And again, also, of course, through the lens of this geoprocessing theory, where we look at this from an inductive hypothesis generating and a deductive hypothesis testing kind of lens. So there's quite a lot of consistency, I think, in the literature. I think that speaks also then to some of your other questions around what happens when the script isn't quite accurate and what we do about that. Cognitive bias is a huge issue in human decision making, and being aware, I think, is a first step of monitoring those biases. And being aware is a process of thinking about this in a metacognitive kind of level. And so any model that you apply to this will help us being meta-aware of the way that we think and the way that we make decisions. And this is really critical because not only is it affecting how we practice ourselves, but also how we teach others to practice as well. Joe, do you want to expand on that?
I was just going to say the Gillespie-Patterson model was born from a nursing background as well. And similarly to what Seb was saying, it's really just one model that helps us systematically look, I suppose, at our reasoning that we just thought was intuitively there. And how we know that experts don't necessarily provide the education that novices need, because it's just all so intuitive. But what we actually need to do is take a very systematic way of unpacking that so we can teach a student how to do that, or a novice how to get better at that. So any of those models really just provides us with a framework and a way of systematically looking at things. It's not one is better than another, perhaps.
That's really helpful. Thank you. And perhaps Laura Jane, there's another question here about, is there a way for experts to reflect on their own clinical reasoning to break it down for clinicians who are learning? perhaps that links to what you were talking about there at the end, Jo, about the benefits of the think aloud approaches and getting people to bring to mind, make visible their thinking.
Yeah, without a doubt. I mean, there's, you know, people won't necessarily put those facts that they're collecting and thinking and considering in their illness script into bundles like we've just discussed. But by thinking aloud, saying, well, I did look at their blood pressure and I looked at their chest and that's okay, but look at their fluid intake and now she's saying that to me. And I know in the past when I've had people with, you know, their goals of care really just to get home and, you know, they don't have long to live, but they want quality, and putting all of that together. So people might not label their thinking in those bundles as we describe them, but they will be there. All of that stuff will be there in that expert's thinking. And if they can do that in a think aloud way, and they have perhaps the novice has a bit of a system or a framework in front of them to look at, oh, they've done that, oh, they've done that, oh, they've done that. And I need to be holistic like that too.
Maybe just to expand on that anecdotally, Jo, from when we did our reasoning research, we observed that a lot of the reasoning does come quite intuitively, but what isn't intuitive is the talking about the intuitive reasoning. And so we found that in our data collection initially, we really had to, in a way, upskill and make clear to participants what we actually wanted them to do, because they were so naturally used to these things happening inside their head rather than verbalizing them, and then verbalizing them in a way that sort of said, okay, well, that bit led me to think something and this bit actually confirmed something else. And so I think if we can break through that and capitalize on that in university and clinical education by unpacking our own reasoning and verbalizing that, then that's one step towards trying to make this otherwise black box kind of thinking a bit more visible, and then be able to teach it.
I could keep talking here and have to be careful not to, you know, I suppose hog the microphone. But I think from a clinician, you know, doing some teaching in a clinical setting, I think what the Think Aloud does as well is create that open dialogue between the educator and the learner. So it's much more out in the open than as to what knowledge the learner has acquired, you know, and so that I then as an educator or trainer can help then, you know, bridge the gap or, yeah.
Absolutely. And can I add to that, Michelle? The other way I think is important as well, or can contribute in some way. We get our students to unpack why they are thinking what they're thinking. It helps us understand perhaps different ways of doing things, and that different ways of doing something can also lead to a valid positive outcome. So going back to that example of 27 times 3, you can solve that equation in lots of different ways. Maybe some ways we wouldn't have thought of initially, but we get to the same outcome. So there might be a value then in getting students to unpack, not just for their students' meta-awareness, but for expert, seasoned clinicians' benefit as well.
Yeah.
Fantastic.
Yeah, I know Sue had some really specific questions she asked in her interviews during that Think Aloud process to really tap into the reasoning. So you may or may not be able to come up with any of them on the spot, but it was like, you know, what made you think that way?
Yeah, so what made you think that way? What that you think about that or make that position and do that? Yeah, a lot of prompting around what they're doing and why they're doing it.
So, you know, another suggestion might be we can provide that to our students when they're out on placement, so they can actually start questioning their expert clinicians about their clinical reasoning. Just one thing about that script, what if it's born of inaccuracy? I really, really like that question, because we bring so much cognitive bias and so much bias from our own experiences when practices do move on, when research does move on. And I think, we need to be ethical practitioners and always be keeping up with the evidence and being evidence-based practitioners. And, EBP is about, what we learn from our patient, what we have of our own experience, but keeping up to date with research and then putting it all into the context appropriately. So yeah, really good question, that one.
Thank you so much. Can I ask you just to skip, I know we're going to be sending out, I think the plan is to send out the recording to attendees. Would you guys just mind skipping ahead? I think it's excellent if our audience members can connect with you directly, because I think, this will just sort of light a spark, I think, for many of us to, think about our thinking. And so you may get a few emails in the inbox to follow up on this. I mean, actually, just before you go off, can I ask a question? Which professions are looking at this well? Like I think all of you across your talks talked about looking at the literature outside of speech pathology. Which disciplines, if we're sort of just staying clinical, which disciplines or professions are perhaps ahead of the curve, or are we sort of working in unison a bit on this in terms of how we're looking at clinical reasoning?
I think there's a bit of both, Michelle. That's a really good question. I think there's unison around the interest in this area and the recognition that meta-awareness can really help us unpack our reasoning and therefore make it easier to understand and in some ways check and balances that as well. Psychology is obviously a very strong field in this area, and the medical education field has got a fair bit of evidence as well. I think in allied health, we're catching up on creating some of this evidence, but I think it applies in many, many similar ways as it does in medical education and in psychology as well. So I think it's a great opportunity to look at multidisciplinary research as well. So, how do different disciplines engage in reasoning but get to similar endpoints? And then, of course, that raises the question of how we communicate with each other and how we unpack our own reasoning for and with the other disciplines, so that perhaps the translation of management plans from one profession to the other who's implementing that become clearer and easier to implement. And this is actually just a plug here, Sue, for your PhD research, looking at how this all unfolds in the disability space, where speech pathologies make mealtime recommendations, support workers implement them, and then there's, of course, the client as a stakeholder in that triad as well.
That's great. Thank you so much, Seb. And I think on behalf of the committee and the audience, I want to thank you for the work that you've been doing on this. And thank you for your presentation, for so generously sharing your knowledge, which, we know is just but a snippet of the knowledge that you have on this topic. So again, I think we feel very fortunate to have had you present to us today. Any final comments from anyone? No?
Thanks very much for having us. We really appreciate the opportunity.
Yeah. Thanks, everyone.
Thank you
very much.
And thank you, everyone, for joining us today. It's been a fabulous turnout. So thank you. Okay, I think we'll close. Thanks again, everybody.
Thanks, Michelle. See you soon.
Bye. Bye.
Thank you.